we have come to the discussion part, and I would like to invite all our speakers to take part in the discussion.
We have less time. Okay, I have a question to Dr. Mansouri. You gave us enough interesting, very interesting, fine information about different gadgets, or better to say different devices. And the question is, just for your imagination, can you describe us the best future device for IOP measurement in vivo?
Future device for tonometry should be a device which can obtain reliable round-the-clock IOP measurements, not just for a day or two, but for the long term. Because we have seen that IOP is very variable. And even if you obtain a single 24-hour measurement, it's not necessarily reproducible in the short term and even less in the long term. So to me, the ideal device in the future would be a sensor that we can implant, hopefully as miniaturized as possible and hopefully as safe as possible, which then allows patients to obtain at home measurements easily whenever they wish. I think we are getting there closely. There are several startups that are really working actively in this field.
Okay, thanks.
Thank you. Thank you. Very interesting answer. And I had a question to Dr. Remo Susanne. Please comment about this drinking water test. In your opinion, which patients are the candidates for this test, the best candidates for this test?
Thank you for the question. It's a very important one. The water drink test consists in drinking 7 ounces of water in 5 minutes and measure the pressure before the water drinking and then 15, 30, and 45 minutes after the drink. The peak pressure usually occurs in the 30 minutes. As everybody said, and there is at least 11 papers or 12 papers in agreement, peak pressure is the most important parameter for glaucoma progression. There is no doubt about that. Kawe showed that. And that is the reason to have a device that monitor the pressure 24 hours. But still, everybody knowing that, very few people, very few doctors measure the pressure more than one single intraocular pressure measurement every 6 or 4 months. That's unbelievable. That's why many authors referred that unfortunately it's not possible to estimate the chance of a patient maintaining vision once they have been diagnosed with glaucoma. So if peak pressure is most important and patient, the best way to avoid progression is to avoid peak pressure. The best thing would be do the water drink testing every patient, but I know that in some clinics this is impossible. So the best, I would choose the patients with moderate or advanced glaucoma because further progression may jeopardize the quality of vision. It's a very simple test and it's estimated the peak pressure. There is no positive or negative value, only it detect the peak pressure of the day, which is not necessary to measure the pressure 24 hours. I hope you could hear me.
I totally agree with you. Indeed, we very often lose the very important information on IOP, and we have one more question from the audience.
Yeah, Russian doctors decided that today Dr. Mansouri is a main expert in everything that concerns tonometry. So the next question from our Russian listeners, the idea is, can you tell us your favorite gadget for intraocular pressure and here ocular response
analysis.
It's interesting, but we have some in our country, Corvis, and so on. We do not discuss the price, yeah, but the characteristics. What's better?
Yes. I would say my ideal tonometry device has not been invented yet. My main tonometry device in the clinic is Goldman. We also use the iCare in the clinic, often as a screening device. And I like the iCare Home, and we give it to our patients. We rent it to them for about a week or 2 weeks in patients where we suspect that we are missing peak IUP during the clinic. So we rent the patient the device. For research purposes, my favorite device is the NUMA tonometer, which is a very reliable device. And it also provides us a printout, which is important so we can keep an objective record in research studies. Concerning the ocular response analyzer, its tonometry measurements have been shown to be less reliable than Goldman applanation tonometry or the iCare to some extent, or pneumatonometry. However, this device has the advantage that it provides you ocular hysteresis measurements. So it gives you an idea of how rigid or soft your eye is. And this has been shown by several investigators, colleagues from UCSD in San Diego, Felipe Medeiros, Professor Weiner, and others. It has been shown that there is a correlation between ocular hysteresis and the risk for glaucoma progression. And this is a value that the ORA provides us, and I believe it has valid and it has a play in any tertiary glaucoma center.
What about Pascal tonometer?
Well, the Pascal, that's a good question. You know, Pascal is one of those actually great inventions which never managed to impose itself. Why? Probably because it's similar to Goldman applanation tonometry. You know, the device looks similar. You mount it on your slit lamp, but it is better than Goldman. It is better because it is less dependent on corneal properties such as CCT, central corneal thickness. And it also provides you measurements for about a minute or more and gives you an idea of the ocular pulse amplitude, which probably also is interesting in glaucoma. But the device is so similar to GAD that many colleagues then wonder why should they spend more money on it? And the measurement itself is a bit more cumbersome, at least until you really get used to it. So it never managed to impose itself on Goldman, which I think is a pity.
Thank you very much. We totally agree. We also published a paper several years ago about the importance of hysteresis as the predictor of glaucoma progression. That's why we use ocular response analysis in our clinic. But I would like to emphasize that during the COVID pandemic situation, indeed, we should think about the proper method of tonometry with tips, and we have to change them. And from this point of view, home tonometer and iCare, I think that is a very useful device. Thank you. And I have a question for Leopold Schmetterer, please. The question is, the question concerns OCT angiography and much more. The doctors would like to ask you about the perspectives of the ocular blood flow measurement in the nearest future, and is it indeed very necessary information? Should we measure ocular blood flow in clinical practice?
I think at the moment this is not supported by current evidence. The OCT angiography and other techniques is still a research tool. I don't think that it makes much sense. I think there are some perspectives for the future given the strong structure-function relationship and also giving progression in late-stage disease, which is generally a problem in clinical practice because OCT, classical OCT shows a plateau and visual fields become usually very variable in late-stage disease. So we still have no good means to really detect progression in late-stage disease, whereas it's actually extremely important to detect progression because these are really people that have a very high risk of getting blind. And I think this is something that we should maybe look at, what is the is there a role for OCT angiography in late stage disease? I must also say you have to be a little bit careful because OCT angiography readings are influenced also by many other diseases. We know that there are changes with diabetes. We know that there are changes with hypertension. We know that there are changes with kidney disease, with Alzheimer's disease, with multiple sclerosis, with Parkinson's disease. And it is extremely difficult when you only look at OCT angiography to figure out whether a change that you see is only related due to the glaucomatous disease or also influenced by any concomitant disease that is very prevalent in this elderly population.
Thank you, Leopold, and thank you very much for your cooperation and for your help in our symposium. Thank you. So, dear colleagues,